Hello, I think we're live. So my name is Steven. I am Deputy Lab Manager and Embryologist at Care Fertility in Northampton. And tonight we're going to be talking about kind of introduction to IVF and kind of explaining all the processes, how it works, etc. And this is my colleague, Ali.
So hi everyone, my name's Ali Richardson. I am a consultant and subspecialist in reproductive medicine, and I am based primarily in Northampton with Steven, and we're just going to talk to you this evening about what you might experience if you do decide that you want to come through for IVF treatment.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex. We get single patients wanting to start a family. We get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualised treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us, so we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic, and even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, and I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
Hello. There you are, Ali. I'll do this bit and then I'll hand over to you for the initial treatment in things. So yeah, we're Care Fertility. We're one of the largest private providers of fertility treatment in the UK. We've got clinics all over, and we've recently acquired a couple of clinics down south as well, which should be available sort of to use as part of the group early 2024, first couple of months, I would have thought. We've recently acquired a clinic in the USA, and we've got 3 clinics in Spain now as well, so kind of ever expanding, and obviously helps with availability and accessing treatments, as well as the main clinics. We've got lots of satellites as well, where you can access for scans and things like that, and consultations. Yeah, we have a kind of a GEM team, so an initial inquiry team, which use kind of the main phone line, which you see on the website, that you can phone up. They'll direct you to the right place. They're able to give kind of advice on certain types of treatments and where's the best place to go, and who's kind of point you in the right direction, really, and just sort of that initial contact point. And it's all managed as a central team as part of the whole care group. So if you phone the main number, it'll direct you to all of the different clinics, and they'll put you in the right place. And then I'm going to hand you over to Ali.
Okay. So obviously it's really important that we get the right diagnosis for you, and you know, there's lots of different reasons why couples might struggle to get pregnant, and we don't treat you all the same at Care. We sort of individualize the treatment that you get to to sort of match any problems that you might have. So before we see you for the first time, we'll ask you to have a few baseline investigations, so that we know when you come for that first appointment, we know exactly what we're dealing with, so that we can not talk generally about people in general, but talk specifically about you. So the investigations that we will ask you to have, so the first one is an AMH blood test. If we could just move the slide on, lovely. So the first thing, this is a test for the women, and it's just a simple blood test. AMH stands for anti-Müllerian hormone, which is a hormone that's produced by the follicles in your ovaries. So we know that women are a bit of a design flaw, but we're born with all the eggs in our ovaries that we're ever going to have, and from the moment we're born until the moment we go through the menopause, we're constantly losing eggs, and so a good predictor of your ovarian reserve is how old you are, but not every woman of the same age is identical to everyone else. So we have these tests that we can do to look at your specific ovarian reserve, and then that helps us tailor the advice and the treatment that we might offer you. So one way of assessing that is the AMH blood test. The other way of assessing that is called an antral follicle count. So this is an ultrasound measure. So it's an internal scan, which you'll learn to get used to, and it counts the follicles on the ovaries, and again that gives us an idea of how you might respond if we were to put you through an IVF cycle. And again, it helps us tailor the treatment for you. The other thing that we look for on scan is any abnormalities, so any polyps, any fibroids, any big cysts on the ovaries, or anything else that might influence the treatment or the outcome of treatment. And then the third investigation that we will ask you to have is for the men, and this is a sperm sample, and we will look at lots of different things, but most importantly the concentration, the motility and the morphology of the sperm. So like I said, we'll ask you to have all those investigations before you have your initial consultation with one of the consultants, and during that appointment we will go through your history, so that we know exactly where you're coming from, and any investigations or any treatments that you've had before you've come to us. We will also discuss the results of the investigations, that you've had, and then together we'll come up with a plan that everybody's happy with, so that there may, for sometimes there's different options, and other times there's a very clear cut kind of treatment plan, but we'll discuss all of that with you and explain why we recommend one treatment more than another, for example. And so you'll be supported throughout this by the patient portal. So there's sort of no paper trail of anything. So everything that if you've had any investigations done elsewhere, you can upload those to the portal, and all communication between the clinics and yourselves will be done through a patient portal, and that just means that things happen very quickly, because as soon as you upload it, it's there for us to see, and vice versa. Okay. Once we've had that initial consultation, and if you decide that you do want to move forwards with IVF treatments, then we will talk you through that in detail, and so what that usually involves is so if you imagine your ovaries look like a bunch of grapes, and each grape is a follicle, and inside each follicle is an egg. Normally, once a month, your brain will send a little hormone signal to one of those follicles, and that follicle will get bigger and bigger and bigger, and eventually it will release the egg, and then that's the egg that could potentially get fertilized that month. But we know that most women have, several follicles in their ovaries, so what we do with an IVF cycle is try to stimulate your ovaries so that all the eggs, all the follicles get big all at the same time, and then we can potentially get an egg from each of those follicles. And the way that we do that is with hormones. It's the same hormones that your body produces naturally, but your body just produces a small amount of hormone because it just wants to stimulate one follicle. We want to stimulate as many follicles as we can, so we give you a much bigger dose of hormone, and all those hormones are injections, and that can be a little bit scary, and when you think about it, but actually most people say it's not as bad as they thought it was going to be. You can probably see from these pictures, but the needles are actually quite small. They just go underneath the surface of the skin. They're called subcutaneous injections, and the nurses will teach you how to do this yourself. And as I said, it's really not as bad as you think it might be. So you'll inject yourself usually for between about 10 to 14 days. And during that 10 to 14 days, you'd need to come into the clinic for monitoring scans so that we can monitor the growth of the follicles and make sure that they're growing nicely. And, sometimes we need to tweak the dose of the medicines to, if they're growing too quickly or too slowly. But like I say, we will individualize that to you as you come through for treatment. At the end of that 10 to 14 days, the scan will hopefully show that you've got a good number of follicles that are all above a certain size. And we then give you one last injection, which is called the trigger injection. And then 36 hours later, you'd come into the clinic to have your eggs collected. That egg collection procedure is done either under conscious sedation or local anaesthetic. And the way that we do it is with an internal scan. This time the scan probe's got a needle attached to it, and we put the needle through the vagina into the follicles of the ovaries, suck out all the fluid that the follicles contain, and give that fluid straight away to the embryologists. They look at it under the microscope and count and collect the eggs. It usually takes between about 10 and 15 minutes, and as soon as you wake up, we'll be able to tell you exactly how many eggs we've collected. Whilst the woman is in theatre having her eggs collected, the man is producing his sperm sample, and then that afternoon the embryologists will fertilise the eggs in the lab, and this is where I hand over to Steven, who will talk you through that in a bit more detail.
Thank you. So yeah, sperm collection, it normally for most patients, it's kind of partner goes up into the room, and it's normally sort of through manual masturbation that we acquire sperm samples. It can be done from frozen samples at other clinics. We can import them. We can do SSR sperm, so surgically retrieved sperm if needed, and we also use donor sperm, obviously. So we can kind of do most sperm samples. We thaw them out if they're frozen, but for the most part, we use a fresh sample where possible. We again look for the number of sperm that are swimming, the total number of sperm in the sample, and sometimes what they look like depending on the treatment that we're using. Here's a really good video that kind of shows us the sperm swimming around and one of our electronic assessment systems. So you look at the total number of sperm, and it comes from the diagnostic semen analysis, your treatment type. So for most patients, the treatment type at this point is already decided, and we'll kind of just prepare the sperm. So we're washing away the seminal fluid and just really sort of taking away those individual sperm cells from the fluid they come out in, and kind of put that into some media. There's a couple of different ways we can do this, but for most people it's a centrifugation, so we spin it around in a tube and it brings it down to the bottom. Can we move on? Is the video finished? 2 seconds. Yeah, cool. Oh, lost my slides. Bear with, sorry. Next one, cool. So the next stage for us in the lab is fertilisation. There's 2 ways we can do this. So we can do what's called standard IVF. So we mix sperm and eggs in a dish, and that goes kind of, it's the more natural way of doing it, but it does depend on the sperm sample that we've got. You either have kind of normal parameters, and that allows us to prepare the sperm in such a way that we've got enough to be able to sort of mix the sperm and the eggs together, put sperm at one end of the dish, eggs at the other, and they kind of find themselves overnight and hopefully fertilise. The other way is something called ICSI, so that's intracytoplasmic sperm injection, and that's where we inject a single sperm into each of the eggs that we collect. It takes a long time to train, and you can see the pictures there with the big microscope and a video of obviously one of my colleagues doing this. So what you're doing is you're kind of picking up an individual sperm and you're directly putting it straight into the egg. It overcomes a lot of male factor problems where the sperm don't meet the egg or the egg doesn't recognize the sperm, because you're kind of bypassing all of the interaction that the sperm needs to do past a certain point. You kind of physically putting the sperm in there. There is kind of lots of information around this and everything when you go through the consultation, so if it's something you need, they will talk you through it, but it does help to overcome some sperm problems quite a lot of the time, and you're kind of almost guaranteeing that the sperm have definitely got into the egg because you're physically putting it there. The next stage is when we assess fertilisation and then look at the embryo development, so the ways the embryo develops and kind of assess that. Not all of the eggs that we inject with sperm fertilise, and we're not able to inject all of the eggs that we retrieve. So you do see a drop in the number normally. That's completely part of the process, and you're kind of narrowing it down in order to gain the best quality embryo. And ultimately, you want the embryo that's gonna go on to form a pregnancy, or at least most likely to. So you're trying to sort of narrow it down at every step of the way. The best way of doing this really is through what we call embryo development and growing them onto to day 5. So that's what we call blastocyst stage. It's just the name that we call an embryo on day 5 of development. It allows us to sort of assess how they develop and what timings of this happen and everything else. We use an AI platform when we use our Timelapse incubator. It basically assesses the pixels on the screen and assesses how the embryos divide. You can see an embryo here developing into what we call a blastocyst. the way that it does this is obviously an important process in embryo development. It allows us to select kind of which embryos are the better embryos, so how they get there, how long it takes them to get there, and what they look like when they do get there. It also makes the embryos more likely to survive freezing and thawing when we freeze them at this stage, and also it allows us to do sort of PGTA biopsy and sort of assess kind of the chromosomal structure of the embryos. But not all embryos, again, will form blastocysts. So this is something that we call PGTA, and it's a genetic assessment of embryos. And we're looking at whether they've got a normal amount of chromosomes or an abnormal amount of chromosomes. Take a small amount of the embryo outer shell, so the bit of the embryo that forms the placenta, it's also known as the trophectoderm. And what we do is we kind of tear that away from the embryo. It looks a lot harsher than it is, and the vast majority of embryos, above 99% of embryos, survive that process. Then we freeze the remaining embryo, and then we send those cells off for testing. They go off to a separate lab, and it takes a couple of weeks for the results to come back. But what that does is tell us whether the embryo contains a normal amount of chromosomes or an abnormal amount of chromosomes. The embryos with the abnormal amount of chromosomes, they're really unlikely to ever go on to form pregnancies. And if they do, they pretty much 99% of the time end up in miscarriage. So you don't transfer abnormal embryos. But the embryos that come back normal, it almost equilibrates any sort of age factor or anything over the course of the eggs aging. What you find is a really high pregnancy rate when we put embryos back that have been tested and come back as normal. Obviously, the part of the process is gaining embryos which are normal, and obviously the older you are, the less likely you are to get embryos that are normal. But it helps to sort of identify those embryos without having to go through numerous sort of transfers of embryos that would never have formed pregnancies in the first place. So it allows us to select them down a lot better, as well as all of the care maps and the AI systems that we use and how we see the embryos develop. This is kind of how we're selecting the embryos out in the lab. The next stage is the embryo transfer, and I'm going to hand you back over to Ali because this is something predominantly that's done by the clinician.
So the embryo transfer, as Steven said, our sort of default position is that we would do it on day 5 when the embryos are at the blastocyst stage, and the reason for that is because it's much easier to differentiate the good quality embryos from the less good quality embryos, and we obviously want to transfer the embryo that's got the highest implantation potential. There is a question in the chat about someone that's had treatment previously and unfortunately their embryos didn't get to the blastocyst stage, and if for anybody that's experienced that before, we would look through your previous treatment cycle and look to see where the embryos perhaps stopped developing, and there's lots of things that we can offer you to improve embryo development in any subsequent cycles, and we would obviously talk you through that in more detail during the initial consultation. We used to many years ago, and it makes me feel really old because it's what we did when I started doing IVF. We used to do transfers a little bit earlier on day 2 or 3, but we like at that stage, it is quite difficult to differentiate the good quality embryos from the less good quality embryos. So although we can technically do a transfer on day 2 or 3, we do try to wait until day 5. And the reason for that is because if the embryo sort of fails to develop in the lab, in the dishes, then the likelihood is that will also fail to develop in your womb. So we don't tend to do transfers earlier, but but we can, and we would obviously discuss that with you. Anyway, so the actual embryo transfer procedure is fairly simple and straightforward. It's a bit like having a smear test, which I suspect the majority of women watching will have had a smear test previously. So similar sort of position, similar sort of equipment, and we will pass a very fine catheter through the neck of your womb. In most places it's done under ultrasound guidance, so you'll have someone scanning your tummy, and then someone passing the catheter, and then once the catheter's in position, we will inject the embryo, and sometimes you see a little flash on the screen, not always, but sometimes you do. Usually just takes a couple of minutes. It's usually fairly simple and straightforward, and you usually don't require any form of pain relief. You know, you don't need any local anaesthetic or any sedation or anything like that. There are some women that really struggle with these sorts of procedures, and we do have options available for those women. So we have gas and air available, you know, for people that just need to take the edge off it. We can also do it in under sedation as well, but we would need to know about that in advance to make sure that we'd got you know, an anaesthetist around to do that for you. There's also another question in the chat about someone that's had surgery on their cervix previously, and you know, we have lots of women with lots of different medical histories, and yes, if you've had surgery on your cervix previously, it can make it a little bit more challenging, and you may, if that applies to you, we may offer you something called a mock transfer, and this is when we'd get you to come into the clinic before you start your IVF cycle, and we would do a pretend transfer. So we've got various different equipment available, and we can sort of you know, just try out exactly what we need for you, without having the pressure of an embryo there, and so that when you then come through for your IVF treatment, we know exactly what we're doing, we know exactly what equipment we need, and it makes it a lot easier for us. If you are not having IVF treatment, if we are recommending IUI treatment, so IUI treatment stands for intrauterine insemination, and this is something that often single women or women in same-sex relationships, it's often the treatment that we recommend to them in the first instance, and that is so they're obviously using donor sperm as part of their treatment. And the insemination procedure is very similar to the embryo transfer procedure. So again, similar sort of position, similar equipment. We pass a very fine catheter through the neck of the womb, but rather than inject an embryo, we are injecting the donor sperm, and we are doing that at a time, because we'll have monitored them in their cycle. We're doing it at the point where we know that ovulation is imminent, because you know, that's obviously we want the sperm to be there when the egg gets released. So that procedure is very similar to embryo transfer. After the embryo transfer procedure, you will then go away and you will twiddle your thumbs for 2 weeks, and at the end of that 2 weeks you will do a pregnancy test, and hopefully it will be positive, but if not, we will get you to stop all your medications, and then unfortunately you'll get your well, it's called a withdrawal bleed. It's not a proper period, but it feels like a period, and so in that 2 week wait, everyone will hands down tell you that is the worst part of the treatment. It's much worse than all the injections. It's much worse than all the procedures. You won't need any injections during that period, but we will recommend that you have some progesterone pessaries. So these are tablets that go inside the vagina 2 or 3 times a day. You you learn to love them, I think. They're a little bit messy, but they're essential for the success of the treatment. And apart from that, in that 2 weeks, you can carry on your life as normal. You know, you can go to work. You can obviously you at that point you may be pregnant, so we will advise you on sort of certain foods and things that you need to avoid. A lot of people ask about exercise in that 2 week period, and we sort of encourage you to sort of do gentle exercise, so swimming, walking, yoga, that sort of thing. We tend not to encourage high impact stuff, just because your ovaries will still be quite swollen at that point from the stimulation side of things, so you probably won't feel like doing it, but there's a risk that if the ovaries are swollen, then they can twist on themselves, and that is not good. So gentle exercise, absolutely fine, but nothing too strenuous. And that I think is it from me, and I think Stephen's going to come back in and do the next bit.
Ta-da. So obviously we know sort of families are not quite as simple as man meets woman, woman has child, and there is all sorts of different families out there. We see loads of different types of families. We do a lot of donation processes. We have sperm donors. We have our own egg bank, sperm donor banks. We have our own internal one where we have patients that have donated sperm, or patients that have come to us and donated sperm just altruistically. We also partner up with some of the more sort of commercial banks where they have a larger variety of sperm available. They come from America, the European Sperm Bank, which is obviously a lot of Denmark based, so there's loads of Danish people. There's London, obviously there's lots of different banks, and they have a lot of different samples available. They will give you different information about them, but they were all tested to what's called the UK standard. They have specialised parts of the banks that allocate sperm to come to the UK. They are consented to the same consent process, so they're identifiable as part of the UK law, and they're tested up to the same method of testing that we do. So they're screened for virology screens, they have genetic testing, they've got clinical histories on their family histories and everything like that. So it's a kind of a very thorough process, and you can just kind of have either IUIs, or you can have it for treatment and everything else. There's a lot available out there, and different types of treatments with donated gametes. We have our own egg bank, so we use frozen eggs, and we kind of move them around the country between the different clinics, and you can access that online and look at the characteristics, pick your donor, and then they're kind of shipped to the clinic, and then we use those eggs in the clinic for your treatment, whether that be with your partner sperm or donor sperm or whatever else. And we have a lot available with donor samples in the clinics. This also includes surrogacy as well. So we have patients come to us who, for one reason or another, don't have the ability to carry children or don't want to carry children, and we have a big surrogacy service. So lots of whole team in there that will create embryos for you, whether that's a transfer straight to the host or creating embryos ready for when you do find yourself a host to carry your child. It's obviously a really complicated process, and we do have a whole team set up for surrogacy within the clinic, and obviously, as you can see there, we've won some awards for our surrogacy service as well. Normally we use kind of either patient eggs if you're producing eggs, or we can use donor eggs, and we normally recommend something with PGTA, so you're sort of testing those embryos and identifying the embryos most likely. You're kind of doing everything you can to identify the embryos that are most likely to want to form pregnancies prior to finding the surrogate, or obviously you're trying to sort of minimize the number of transfers that the surrogate might need. But yeah, we deal with lots of surrogacy cases in the clinics. There's obviously a whole support network as well with Care. We're a really long-term established providers. So we have a really big forum and lots of people on there. I know people sort of buddy up with people going through treatment at the same time, just to talk about what your experiences are and how are you how are you dealing with this, or what was your expectation of this, and how has that worked out for you. It's just kind of something that a lot of people wouldn't necessarily talk about to each other in sort of around the pub. So there's specialised areas of the internet for that, and I know there's obviously groups on Facebook and things as well. But our forum's a big forum. As well as that, we have our own counselling service. So we have counsellors in clinic, and you get a couple of counselling sessions as part of the cycle to use. We use counselling obviously prior to using donor gametes always, and prior to doing the consents, we offer you counselling. It's kind of it can be there as either a how do I approach this, or how do I approach this with so and so, or it can be actually I just don't feel well today, or I don't feel like talking to anyone, but someone there to listen. So there's a lot there in the counselling. We have obviously in-clinic teams, so we have what's called a Care Pals team, and that's an admin person that would be allocated to you, and then they can sort of distribute your questions if you have questions, or get someone specific to contact you if you need that. We've got a resource hub that sort of talks about all of the injection processes. There's videos, there's a lot on YouTube from us about how to inject anything that goes wrong, and then we have kind of on-call teams as well. So if you're experiencing problems in the middle of your cycle or anything like that, then you can just call the on-call phone, and the nurse will be available to speak to you. So there's lots and lots of support available from us, and we kind of put every method out there. A lot of the time I just say to patients to give us a call if you've got questions. We'd rather answer your questions and have a chat than leave you wondering and waiting for the next call from us. It's a much better way of sort of doing it, and quite often we quite like talking about our jobs, so quite often it's nice to have a chat. Obviously, as well as that, we have funding support available. So we have what's called Care Pay. It's our own finance-based process, and it covers kind of multi-cycles. Sometimes there's packages where you get a refund if you don't get pregnant over a certain number of cycles. They cover kind of frozen cycles, freezing, and they kind of bunch them all together, and in order to try and save money for the patient, really. And it allows you to access kind of a known price and say, right, this is how much I want to spend on the actual IVF. Obviously there's always variation in drugs per patient, and sometimes there's a couple of little extras in there where you need certain things for certain treatments and they're just unpredictable. But it's a way of trying to standardize the cost that we're charging people, and kind of making that easier to access and giving you a price that you can sort of know up front. Whereas a lot of IVF treatments and the way IVF works a lot of the time is it's very individualized. So you get one person needs £5,000, one person needs £7,000, some patients need more than that, and it really varies. So on a per cycle basis, so the Care Pay packages sort of aim to standardize that, and you can kind of sit back and relax and say, right, I've got 2 cycles. If I don't get pregnant on my first cycle, I'm not going to scrabble around and try and find the money or stress myself out about it. I know I've got that backup, and it sort of supports you in that process. And obviously this week we've got a lot of events going. There's one every day. We're the first one, so no pressure, but there's lots of different events running this week, and we tend to run quite often. I know we run Instagram lives, and there's a lot of resources available, and obviously via the social media anytime. I know if you drop them messages, they're there a lot of the time, and I know the general inquiries teams and things are running while we're running this event, and quite late into the evening. So yeah, this is, I think, the end of the presentation really, and we're going to run a bit of a Q&A. We've already got a couple of questions in the chat, and I know Ali's keen to get answering them, but
Super
we've
keen.
got some that have been sent in.
Yeah,
And,
so we'll just start with some that we were sent in before tonight, just while I think the IT are sorting out the other ones. So there's a lot of people saying, or people that can seem to get pregnant relatively easily, but then have recurrent miscarriages, and they're wondering what they should do next, and whether IVF can help them. So it's thought that infertility and recurrent miscarriages are sort of on a similar spectrum, so it's not uncommon that we do see couples that have had lots of miscarriages previously, and there's lots of different reasons for miscarriages, and the likelihood of problems are different at different ages. So in older women, the main reason for miscarriages are chromosomal abnormalities, and things like PGTA, which Steven spoke about, can help with that. And in younger women, they can have chromosomal abnormalities, but they're much less common, and certainly much less likely to be a cause of recurrent miscarriages. And so in younger women, the more common cause of miscarriages is if you've got problems with your blood clotting, which you wouldn't necessarily know about from sort of normal day-to-day life. It wouldn't bother you, but it can be a problem if you're trying to get pregnant. And other problems might be if you've got abnormalities within the womb, so like polyps or fibroids, or some people have funny shaped wombs that can increase the risk of recurrent miscarriage. So there's lots of things that we can do, is what I'm trying inarticulately to say. So the NHS will investigate you for recurrent miscarriage, but the definition of that is a little bit variable. So some places will do it after you've had 2 miscarriages. Other places will wait until you've had 3 miscarriages. But you can ask your GP to refer you to your local recurrent miscarriage clinic if you want to, or they are investigations that we can do for you easily at Care. And we would obviously, if you've had previous miscarriages, we would recommend that you have those investigations before moving forwards with your IVF treatment, because we obviously want to do everything that we can to make your treatment successful. So I hope that answers that question. Another question in the chat is to do with fibroids and endometriosis, and wondering whether or not they have to have surgery before they have their IVF treatment. With endometriosis, it's not crucial to have surgery, and it depends on the stage of endometriosis, but certainly for advanced staged endometriosis, there is no evidence of any benefit in having surgery before you have your IVF treatment. It's better to just come on and have the IVF treatment. With the sort of mild end of the disease, it's that there may be minimal benefit in having surgery before you have your IVF treatment. But if you're trying to get pregnant naturally and you've got mild endometriosis, then yes, surgery can help. Fibroids is a bit more of a tricky one. So it depends on exactly where the fibroids are growing and how big they are. So fibroids are benign lumps of muscle. They're not cancerous, they're not precancerous, they're just ever so slightly annoying, and the ones that we tend to worry about from a fertility point of view are the fibroids that are growing into the womb, because that's where we're wanting the embryo to implant and for the baby to grow, and if you've got a big fibroid there, it's obviously going to take up space, and so they are the only ones that we would strongly recommend that you have removed before you start your IVF treatment. Other other fibroids growing inside the muscle of the womb or on the outside, we wouldn't necessarily recommend that they need to be removed. Ones that are growing on the outside can make the egg collection procedure a little bit more challenging if they're really, really big. So in those situations, we may potentially recommend that they are removed, but that's not very common. Stephen, I think there was one for you about whether or not couples should consider ICSI even if there's no known male factor. We get asked this one all the time, so I'll let you cover it, and I'll chip in if you say anything wrong.
Yeah, slap my wrist. So yeah, ICSI/IVF, even if there's no male factor. So obviously, as I mentioned, sort of ICSI's, the main reason we use it is to overcome male factor. So if the sperm aren't swimming, there's not enough sperm, or if they just don't look right. The kind of, sometimes when we do IVF, we recommend ICSI if we are not seeing the fertilisation that we expect. So we obviously have average figures of fertilisation when we mix sperm and eggs together. We know roughly how many we should get when we do that. If that doesn't work out first time round, we tend to recommend ICSI, just because this makes sure that the sperm and egg are meeting. As I said, it can be things that are not necessarily based on the sperm. It may be the way the sperm and the egg interact, or the way the egg sort of reacts when the sperm is sort of got to it. So there's that to consider. There's also the oxidative stress, and the amount of sperm that we add can increase kind of the additional stresses on the egg when we mix them together. And if the eggs are not necessarily built to survive that stress, or if they're less able to do that, then ICSI can overcome that, because instead of putting sort of 200,000 sperm in there, and some of them will die and they produce little bits of chemicals that can damage the egg, we're overcoming that. We're putting one sperm into the egg, and that can overcome that. So they're things that they can't sometimes count as male factor, but you can't see them, and they're not showing up in semen analysis, because we just can't look at every single piece of the sperm. And obviously each sperm that we use for treatment is different to the sperm that we've done in the analysis. So the sample that you produce for the analysis is different to the sample that you use in treatment, and we can't test those sperm that we use in treatment prior to using them. So you're kind of limited by that. So it really depends on your individual circumstances, what your history is, and whether that's something that we would use to sort of benefit you in treatment.
Okay.
Is that all right, Ali?
It was adequate, Stephen. Well done.
Thank you.
So another question that's just come in is, do you recommend ICSI when using donor sperm, Stephen?
It really depends on the donor sperm. We normally recommend IVF. So donor sperm comes from the donor banks. They don't freeze sperm. That's not very good. So you tend to have a really good sperm sample. Quite a lot of the time they have proven fertility, so that they'll have had families themselves or as part of their donation process. So they're not just donating one sample, they'll donate a number of samples. In the UK, we can use this for what's called the 10 family limit, if they've allowed us to use it for 10 families. So there's normally some sort of proven fertility there as well. Based on that, we tend to recommend IVF with donor sperm, unless when we thaw out the donor sperm, it doesn't survive properly. Obviously, ICSI is an additional cost of treatment. It's an additional manipulation of the eggs, and it comes with its own risks as well. So it's not a kind of a treat-all that we use for everything. If we can use IVF, then we do tend to try to do that, just because it kind of eliminates all of the extra hassle of doing ICSI and injecting them, the cost of it. So it really depends on the donor, but for most patients with donor sperm, we would recommend IVF.
Okay, brilliant. So a couple more questions. Someone's asked how we make the decision for fresh or frozen embryo transfer. So most of the time we would aim to do a fresh embryo transfer if it was safe to do so. So for the vast majority of patients, that would be what we would recommend, unless they're having PGTA. So as Stephen said previously, obviously it takes 2 or 3 weeks for the results for the genetic testing to come back to us. So we would freeze all those embryos whilst we're waiting for the results. The main situation when we would recommend a frozen cycle is some women develop what's called ovarian hyperstimulation syndrome during the stimulation side, and I suppose the good side of that is that we usually get lots and lots of eggs from them, but in those sorts of situations, OHSS is generally very mild and self-limiting, but the worst thing that we can do in that situation is to make you pregnant, because OHSS is exacerbated by the pregnancy hormone. So what we would do in that situation is freeze all the embryos, wait a couple of weeks for you to feel better and have your withdrawal bleed, and then we would plan for you to come through for a frozen cycle. So that's the main time when we would recommend it. Sometimes some people want to create embryos now, but they don't want to have a baby now. They just want to create the embryos now, and then we would transfer the embryos at a later date when they're ready. But that's obviously their decision to do it. The only times when we would recommend it would be if we were worried that you were developing OHSS. And, a lot of the time we can predict that, and there's things that we can do to reduce the risk of you doing it. So different protocols, different drug doses, different drugs. But sometimes even when we do all of that, unfortunately, a small proportion of women will still develop the symptoms. So we have to warn you about it, and we will usually when you're coming in for those scans during the stimulation, the nurses that are doing the scans will kind of, alarm bells will ring, and they'll start sort of warning you about the possibility of it. But it doesn't happen very often. It's just something that you need to be aware of.
There's another one on the emails actually for you, Ali. It says, do you recommend supplements, etc., at consultation?
Yeah, so the only so the main supplements that we recommend to everybody that's trying to get pregnant is folic acid, and so the usual dose is 400 micrograms, and that's what's available in all the supplements that are that you get over the counter. Folic acid is really, really, really important because it massively reduces the risk of the babies having neural tube defects, so things like spina bifida, and the spinal cord is formed really, really early on in development. So it's really important that you're on those supplements, before you get pregnant, preferably 3 months before you get pregnant. So that's folic acid. Some women will be recommended to have a higher dose, which is 5 milligrams, and that's only available on prescription that either we can prescribe or your GP can prescribe, and that is if your BMI is over 30, or if you're on some medications, and it's usually medications for epilepsy, that we would recommend a higher dose, and also diabetes as well, we recommend the higher dose, but for most women 400 micrograms is fine. And the other supplement that we recommend to absolutely everyone is vitamin D. So vitamin D is the sunshine hormone, and obviously we don't have much sunshine in the UK, and so everyone should be on vitamin D, but specifically especially women that are trying to get pregnant, and the usual dose is 1,000 units, but you can have a blood test to see what your vitamin D levels are before you start, and if they're lower than that, then we can prescribe higher doses for you. So they're the ones that we recommend to everyone. There are others that we might recommend to some women in certain situations, but they are the only ones that have got robust evidence. There's lots of other things that people take, but the evidence of benefit is very, very limited.
Thank you. And the last one on the emails is I think we're going to start wrapping up in a short while. The last one on the emails that we received is another clinic offer time. Oh, this one's for me actually. Sorry. Another clinic offer time-lapse for embryos. Is this the same as Caremaps? So yes and no. Caremaps uses time-lapse technology. So time-lapse is the incubator. So the video that we showed you of the embryo developing, that's what we call time-lapse. It allows us to look at individual frames as the embryo develops without having to keep taking it out of the incubator. And we can pinpoint the times that those embryos divide. So the time it reaches 4 cells, the time it reaches blastocyst stage, or the time it starts to become a blastocyst. Through the use of our own data, we've identified some time points that are kind of clinically important. So embryos that reach blastocyst at a certain time frame are more likely to form pregnancies than embryos that reach it later. So we use that in a sort of algorithmic model, so a mathematical model that selects the embryos based on the way that they develop, the time points involved in that, and then the grading as well is put into the model. This is what we call Caremaps. So it's time lapse and then some on top, and it's all built through AI now. So it's kind of auto-annotated. It picks up all of the different things in the development and it gives it its own score. It's one of the methods that we use to assess the way embryos develop. So it is time-lapse, but it's time-lapse plus. And then I think there's one
more, and you know how I love to have the last word, Stephen, so I'm going to do it. So there's a couple of questions in the chat on polycystic ovaries and polycystic ovary syndrome, and this is something that we see all the time in the fertility clinic. So it's really common, and there's lots of different treatments that we can offer for women with PCOS, and the exact treatment that we recommend will depend on other factors, but we can use ovulation induction with tablets. So there's a couple of different tablets that we can try. There's injections that we can try if the tablets don't work, or if you'd rather go for injections, and then there's IVF treatment as well, and I think someone in the chat said that they're nervous because their periods are really irregular, and what we do in IVF treatment, we normally time at a certain point in your period. We can make you have a period really easily. So if you're, if someone with polycystic ovaries, you don't have periods for, months and months at a time, we wouldn't make you wait 6 months before you start your IVF treatment. We can just give you some tablets, make you have a period when you want to have a period, and then you'll start your IVF cycle really easily. So it's really easy, and we do it all the time, and it's nothing to worry about. I think that is all the questions that we have been sent. Just let me check through that we've not missed anything. Hopefully our helpful IT people will tell us if there is anything that we've missed. Can you see anything? I saw one question about how long does it take to do all of this, so we will try to get you through as quickly as you want to come through, but usually from your initial consultation to your egg collection, assuming everything is fine and we haven't got any extra tests or anything to do, it usually takes between 2 and 3 months. I
think that's all.
I think that is all. Chloe is not sending us any messages, so I think that's our key to wrap up. So we hope
it's time for bed, Ali.
Time for bed. It's time for my wine. We hope you've all enjoyed that. As Stephen said, we've got loads of events throughout the rest of the week. I think that Chloe has a nice little video to play for you now, but wherever you are, we wish you all the very best, and would love to see you at some point in the future in one of our clinics.
Thank you.
Bye.
Bye.
I'm Shah, and I manage Care's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose Care was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with Care that didn't seem to be the case at all. They took everything into consideration, and they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to Care.
Oh, the support at Care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared for by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what care can offer you. To provide you with the best care possible and to give you your best chance of success in treatment, we look to our own care family. From our consultants, embryologists and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.
One in 6 people need help to grow their family. You're not alone. And our care family will do everything we can to help your dream of family come true. There are over 50,000 care babies in the world today, and behind this success is our promise to make more heartfelt dreams of family become reality by ensuring our care goes into everything we do for all our patients every single day. You will receive truly individualised treatment, a patient-centric approach with empathy at its heart. We understand how nervous and excited you might be about getting started, but you can be assured of kindness, empathy, and all the information you need from our new patient inquiry team. We are all here to make it easy for you to take your very first step in your fertility journey. Call our team on 0800 564 2270 to learn more and book an appointment. We don't just care, we are care.